So this morning we're going to talk about the patient-driven payment model, the PDPM, which is effective 10/1/2019. And finally, we're going to have a payment that addresses all that we do as nurses. So for the past 10 years or so, we've been being paid, basically ever since PPS came out, been being paid more so for what rehab did than what nursing did. And there is a significant amount of nursing work that goes into a patient being able to be treated and have successful outcomes and return to the community. Things that weren't being recognized perhaps under the current payment system. So CMS has changed all of that, and that becomes effective 10/1/2019. So we're going to talk about the nursing components and the qualifiers that get us under the nursing component. And for people that are in a case mix state, this isn't really new to you. You already look for a lot of these things and understand the supporting documentation that's appropriate for you to be able to get reimbursed under your Medicaid system. But effective 10/1/2019, this becomes very significant for Medicare payment as well. So one of the highest paying nursing components is going to be under extensive services. So those have a higher CMI, and under this system, the higher CMI translates to higher payment under each of the components. Anybody who falls in one of these levels under this component would be under the presumption of skill. So if they came into the facility and they weren't going to be getting rehab, you would be able to presume that they were skilled, typically just like we do right now for anybody who's over clinically complex. So you need a nursing function score of section GG of 14 or less to get into this category. If you have a 15 or 16, it will drop you out of this category, even if you're getting these services into a clinically complex, which is a lower CMI and therefore lower payment. This particular RUG category is not impacted by depression or restorative nursing end splits. And the qualifiers for these E-level components are either having a trach and a vent while they're a patient, a trach or a vent while they're a patient, or being on isolation or quarantine for an active infectious disease also while a resident. And there's very specific criteria that we need to follow in order to code that on the MDS. All the services need to be provided to that resident in their room. You can't cohabitate them with someone who has a similar disease or concerns or things you're not worrying about transferring back and forth. They have to be in their own room. So we don't capture this as often as some people might think. So one of the things you need to know is if you don't take trachs right now, or you're refusing trachs on admission because nursing staff needs to be trained, they need competencies, we're not up to snuff on this, we haven't taken one in a long time, whatever rationalization you're using right now to not take trachs, you need to look at that. You need to look at what you need to do to get everyone up to snuff so that you can take these. That's the only way you're going to qualify for this category in the absence of isolation. So then you have your nursing special care high, and these are any of the RUGs under this component that start with an H, also included in the presumption of skill, and the CMIs range from 1.85 to 2.39. Not too shabby. You also need the functional score of GG 14 or less. So you'll see a pattern here. GG plays a very important role in PDPM for both the physical and occupational therapy components and the nursing components. And in addition to that, it's also part of our quality measures and our quality reporting. So it's important that we get on board with having these things compliant. They automatically fire for all of your Medicare patients for the first 3 days. If you admit the patient under the wrong payer, or you don't select both of the payment options when you're admitting the patient, section GG will not fire. When that doesn't fire, it doesn't get completed, and the next two in the series do not fire. Likewise, even if you admit them correctly and the first one fires, if a nurse doesn't complete that first one, the second two will not fire. And therefore, the link of that series gets broken, and we have to go back and we have to put in a new schedule to pick up whatever days we've missed because of an improper practice. So we started this in January purposefully so that we could get this mastered before October comes. And here we are approaching June, and we are nowhere near mastering this. This needs to be a top priority for people to get this taken care of. Okay, we can't look to see what the accuracy is until we've established compliance, and we're a long way from compliance. This particular category is impacted by capturing depression symptoms with a frequency of 10 or higher, and we'll talk a little bit about that in a bit. So the things that qualify for this H are septicemia, quadriplegia with a function score of less than or equal to 11. Again, GG playing an important role in whether or not we qualify here. COPD and shortness of breath while lying flat. Daily skilled notes need to be completed and need to be accurate. If you are to open up the various things that we are skilling someone for within that note, all of the things that we need to document to capture any of these categories and all of the care that we provide are built into that note. But just like GG, we've not established a level of compliance so that we can advance to a level of integrity. But it is very important that these notes are completed and that they're accurate. Once you've identified a patient as being short of breath when lying flat and you have that care planned, you will see that in the notes as you're looking at respiratory stuff, but nobody's expecting that we go back and lower the head of the bed every day until the patient turns blue so that now we have daily documentation of the fact that they have shortness of breath when lying flat. And if someone has a diagnosis of COPD and that shortness of breath while lying flat has been identified, it will get you into this second highest nursing category with an H rug. Having diabetes with daily insulin injections and having 2 or more days of insulin order changes. So we're probably not going to find that people qualify for this category much in Medicare on their 5-day assessment. And that's because you're typically not going to see 2 order changes that are specific to insulin. And that does not count just changing because of a formulary need, so that we switch from one to the other because it's not on formulary. It requires a change that is related to the patient's care and a need for that. IV fluids in-house or in-hospital are going to capture this, so it becomes very important for us, again, to make sure we're looking at hospital documentation for continuity of care as well as reimbursement. 2 of the biggest opportunities, I think, within this section are for our respiratory therapy 7 days a week, as well as identifying a fever for pneumonia, vomiting, weight loss, or tube feeding. So in order to be able to take credit on the MDS for respiratory therapy 7 days a week, it has to occur. And so this could be your nebulizer treatments. We need 15 minutes per day. So several different nebulizer treatments throughout the day can equal that 15. That's fine. It needs to be 7 days so the patient can't be refusing it one of those days or not receiving it or out on an LOA and didn't get it. So we need to have that. We need to have assessment that we're checking lung sounds before and after. And even after you do all of that, the only way this is going to count on an MDS is that there's also evidence that the nurse who completed that has been trained in respiratory therapy by the respiratory therapist or someone that a respiratory therapist trained. So if you have an oxygen company who comes in, provides this to your staff, we have evidence of it in their personnel folder, we can take credit for the nebulizer treatments those nurses provide. If you don't have that, we can't take credit. So MDS people have to make sure that the people we have that in their folder. We're familiar with the nurses that are providing the services. We have systems in place that when someone is a new a new hire, or that we have agency staff or float nurses, someone else, that those people have evidence of being trained in this if we anticipate taking this credit for respiratory therapy and getting this special care high. The next opportunity would be fevers. So a lot of folks come to you with pneumonia diagnosis, some of them experiencing weight loss. Others might be vomiting because they're sick or vomiting soon after they're admitted to you. And some may have tube feeding. Unless you have a fever with these things, with the exception of tube feeding, you're not going to qualify for anything. So it behooves you to establish whether or not someone has had a fever. So I ask you, do you know what constitutes a fever? And I have gone up to nurses and asked them all throughout a single facility and have received 3, 4 different answers at any given time. Anything over 101, anything over 100 point whatever, anything over 99. And the real answer is that it's 2.4 above baseline. So again, we need to look at our systems. Has your facility established baseline temps on everyone? So we're putting together a protocol for how that's going to happen, how we get a baseline temp established for everybody in-house now, so that when you send someone out to the hospital and they come back to you, we've already established a baseline and we can determine right on admission or readmission that they have a fever. And then there will also be a protocol for how we do this with new admissions. So the next highest level under nursing would be special care low, and these would be the rugs that we capture with an L. Also included in presumption of skill, the CMI is 1.43 to 2.07. Section GG, again, playing a very important role. If it's at 15 or 16, you're going to drop again out of this higher paying category to clinically complex. It is impacted by capturing depression with a frequency of 10 or higher. And these qualifiers are your cerebral palsy, multiple sclerosis, Parkinson's, again, all being driven also by the section GG component. When it's not done accurately, then we have trouble falling into these categories and supporting why it is we code something the way we do. Your tube feeders that don't have that fever we just spoke about will fall into the special care low as opposed to the special care high. People who receive oxygen and have diagnosis of respiratory failure, people who get radiation or dialysis. And then what becomes important here is you can see that there's a series of skin things that qualify you for this. And it can be an infection to the foot, a diabetic ulcer, 2 or more stage 2 pressure ulcers with 2 skin treatments, a single stage 3 or 4, or a stage 2 pressure and a vascular. Classifications of wound is imperative here. Miscoding a diabetic ulcer as a stage 2 pressure ulcer with no other wounds will disqualify you for this category. So it's very important that the person who is taking care of your wounds knows what is the cause of that wound and classifies it appropriately. You don't want to miss out on this category because we've called something that it wasn't and that it didn't meet this criteria. And then we have clinically complex, and these are the nursing rugs that start with a C, also included in presumption of skill, CMI ranging from 0.94 to 1.86. So you can see that that CMI is lowering with each of these categories. So of course, the optimal categories are the ones that we're shooting for and making sure that we look for all of those things within a medical record and all of the documentation that's necessary for us to be able to code that on the MDS. These are the people with hemiplegia, burns, chemo while they're a resident, oxygen while they're a resident, IV meds while a resident. And so what I want you to know about this as a resident, if someone goes out to the emergency room and they go in an ambulance and they have oxygen and they come back to you, just because it wasn't delivered in the facility, that patient is still a patient of yours, and that qualifies. So a lot of times they come, they take the person in an ambulance, they have them on oxygen, they take them to the hospital and do whatever, to the ER, and they send them back to you, and they're not on oxygen. You need to look at that ambulation or the ambulance transport documentation. They have BLS, ALS documentation for that transport, and you should look at that to see if the patient received oxygen, particularly if you were sending somebody out for shortness of breath. Okay, that's one of the basic things they do when they're transporting someone, and you might not even know it because when they come back to you, they don't have it. They didn't have it when they went out, so you don't think of it. Okay, same thing, IV meds. You know, they go out, they go to the emergency room, they give them 1 dose of something, bring them back. It doesn't matter that it wasn't delivered in the facility. They were still your resident because they hadn't been discharged anywhere. Okay, so here's the depression that we're talking about, that you get captured under that special care high, special care low, and clinically complex. So the first thing you need to know is that you do not need a formal diagnosis of depression to show signs of depression. So one of the things as we're having our meetings and we're talking about, and you guys did your case studies, people are coming back and saying, well, I think we had an opportunity because we missed this diagnosis of depression. The diagnosis of depression, an ICD-10, antidepressant medication, is not what qualifies someone for this end split. It's the answers and the frequency to these questions that you see on the screen right now. And so your staff often don't want people to think that their residents are depressed. But your short-term people particularly are coming to you more debilitated than they've probably been, nervous that they may have to be placed here permanently and lose their home. They're not feeling well. All of those things can certainly have somebody having little interest or pleasure in doing things. I have that on any given day. I don't have a diagnosis in my record of depression. I don't take an antidepressant, but I still can have little interest or pleasure in doing things. And that, what is the frequency of that? Is that one day out of the past 14? Is it 2 to 6 being several days? Is it almost every day? There's no right or wrong answer. There's no good or bad, but it needs to be addressed, and we need to take care of it from a care perspective, and we need to take credit for it for a payment perspective. Feeling down, depressed, or hopeless, trouble falling or staying asleep. I can't do that. Sometimes people sleep too much. What's going on with that? Again, you don't need a diagnosis, but if you have these symptoms, we need to have a way to identify those and document them. Feeling tired or having little energy, poor appetite or overeating. I could have any one of these things. Plus, 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 plus. Feeling bad about yourself or that you have a failure or let someone down. Trouble concentrating on things. Hello, PDPM. Moving or speaking so slowly that other people could have noticed, and then thoughts that you'd be better off dead or hurting yourself. So these are the questions your staff, your CNAs, your activity staff, your social workers, your floor nurses, those are the questions they need to be mindful of, the things they need to be looking for in their patients, and then be able to go to PCC and document that. Again, we have a tool that's in PCC that has not been getting used appropriately. We will work on that through our workshops that we're having in June with the directors of nurses of MDS coordinators, and we'll move forward with getting this documentation from all sources so that we have stuff to support how we code it on the MDS. And then one of our catch basins towards the end are for behavioral, cognitive, and reduced physical function. And these would be the RUGs that are starting with Bs or Ps. And you see that CMI at 0.66 to 1.57. Again, basically a catch basin for the residents that don't have real clinical complexity. They would not be considered presumed skill. But under this component, but they might qualify it for the category they fall in under PT and OT or under speech or under the NTAs. The qualifiers for this is that someone has impaired cognition or behavioral symptoms such as hallucinations, delusions, verbal and physical behaviors towards other behaviors that aren't directed towards others, rejecting care, and wandering. So that is the nursing component in a nutshell.